So one of the things that we deal with quite a lot at the Net Patient Foundation is all the other aspects of a patient's illness and issues and impacts other than whether their tumour is stable or has grown, which tends to sometimes be the focus of our healthcare professional community. So you'll review their scans, they'll come to clinic, you'll give them the results, they're all stable, off you go. And patients tell us time and time again that they didn't really want to bring up the other issues that were actually really affecting their quality of life because they felt that they didn't have enough time or maybe slightly embarrassed to mention these things because they're probably not as important as their tumour, and the fact that they've got stable disease, the doctor feels quite happy with that. So there was a real awkwardness in trying to ensure that the really important issues related to that individual patient was shared. And we found out, so many times that they felt easier talking to the nurse about some of those issues than they did the doctors themselves. But we do feel quite passionately that all healthcare professionals should be able to look at the patient in a holistic view and really try not to just focus on the science and the RECIST criteria, because that's not always what the patient wants to talk about. And it was really highlighted to me when a middle-aged gentleman came into clinic. He had a GI net, but he had refractory carcinoid syndrome. It was really, really difficult for us to control his symptoms. We tried various different treatments, and he was actually incredibly unwell. And he had to do his quality of life score, which at the time was sort of 1 to 9, 1 being nothing, 9 being top. And that was important for us to see what that was like, to look at what the next treatment might be. So when he came into clinic and we took the scores and we read them and walked through it with him, his score was 9 out of 9. I was like, maybe he hasn't read that properly, because obviously 1, 0 and 9's the best. And I said, oh, have you read that correctly? Is that what you mean? Like, you've got really the best quality of life you can have? And he said, yeah. He said, his expectations had been managed. He knows that there probably wasn't going to be another treatment, that it was very difficult for us to control his syndrome. But he was at home every day, so he got to hang out with the wife that he loved all the time. His kids came around all the time, usually come once every couple of months for Sunday lunch. They were there all of the time. And he felt, to him, because of the expectation that he didn't expect to have a huge change in his health, that his quality of life was the best that it could be. And that was the most important thing to him. And he was very, very adamant that he had the best that he could have. And I thought, oh God, that gave me shivers when he was talking, thinking this is what we really must focus on. And so out of the foundation, we started doing this program of education amongst healthcare professionals, mainly junior doctors. So these are obviously doctors who have qualified, but they're F1, so they're in their foundation year, and also trainee GPs. And I'll just share a bit of the experience of that with you, because it has been quite interesting. Obviously, we needed to ensure that what we were saying was relevant. We needed it to be really concise, so we were often offered an hour within the training program once a year, which isn't a very long time to discuss the huge subject that is neuroendocrine tumours. We obviously wanted to talk very much about the holistic approach to care, as we know from our patient community that impact and understanding the impact of disease is often the missing factor when you're having a consultation. We wanted to promote excellence and share, the work that has been done within the healthcare community. It had to be evidence-based, and it was really important that every time that we went to do this, we took a patient with us that could share their experience. So we did 3 types of training, as I said, and what obviously sticks out to me about one of those training days was the trainee GPs, who a couple of them stood up and wanted to present some of their experience. And one lady said, I feel really bad. I think I've probably missed so many neuroendocrine tumours. I've never even thought about it as a differential diagnosis, never even crossed my mind. We don't learn about it. We hear a bit about carcinoid, which is a very old terminology, but in training, but that was it. So if we could try and target the junior generation, and we could maybe find the neuroendocrinologists of the future. And that was kind of our remit. So we went with the simple principle of training. So we had to think about who we were talking to. We had to think about things that we could talk about that they could relate to, depending on whether they were junior doctors or trainee GPs or nurses. We had to kind of gather the level of interest. So trying to sort of use scenarios to understand what it was that they felt was important. And it was really obvious the difference between the junior GP, the trainee GP training, and the F1 doctors. Because the trainee GP said, I don't need to know about diagnosis. I don't need to know about that pathway to diagnosis. They felt quite adamant about that. I need to know what I can do for follow-up. I need to know what I can do to support the patient once they finish with their specialist service and when they need things in the community. And the F1 doctors were very different. So they wanted to know about tests and investigations and the diagnostic pathway. So it was really important, and we got it wrong for a couple of occasions, realising that, they probably don't want to know about that. So we changed that around, and it was certainly very important. And of course, it was important to share what our community was saying, and that communication was the key, and that's what we talked about a lot, and quality of life. So this is the vague sort of timetable of topics that we covered. And I would say that the bottom half, sort of the psychological impact and communications, probably took up half of the session. So that's how little we did on everything else around neuroendocrine tumours. We had to try and explain the concept for our community, that you have a diagnosis and you expect that, you'll go for treatment and then that will be okay, because that's quite a cancer pathway, a known cancer pathway. Treatment will work or treatment won't work. I mean, it's very different for our community, and often the reality, obviously, is the picture below. We tried to talk a lot about communication and the multi-agency team. So we talk a lot about multidisciplinary teams in clinical practice and in our hospitals, but actually in reality and in healthcare in practice is a much wider multidisciplinary team, and it isn't just those doctors that sit without the patient there deciding on the treatment for the patient. There's a huge amount of other people around there that need to be included, even organisations like ourselves, community nurses, psychotherapy, dietetics. So there's many more people that we need to think about, and that we need to use all of the expertise of different people and try very hard not to think as a medic that you have to cope with all of the issues that there are with neuroendocrine tumours. And when we were at ESMO presenting the poster for the unmet needs, it was very interesting. One of the doctors came up to me and said, obviously psychological support was very low and patient information was quite low in terms of what people perceived as an unmet need. He was saying, I can't do all of this. I don't have the time. And I said, well, you're not expected to, because there's a team of you. And you need to refer the patient to other people with other expertise, and you can focus on your expertise. And there was definitely a sense of, well, I'm supposed to do all of this, I'm their doctor. And it's not the right sense, and it's not the right thing for the patient, because they might need various other levels of expertise to support their journey. So we talked about balanced approaches and good communication. There's a huge array of research that talks about the emotional impact on a patient and how it affects all the other health-related issues. And so if we don't provide honest communication, and if we don't provide simple explanation, as Joe was saying, in understandable terms, if we don't have clarity and patient involvement in treatment planning, it's not your decision to decide what a patient wants, it's a decision you make with the patient, that promises are kept. I think one of our highest reports of dissatisfaction within our services is that I phoned the nurse, I spoke to her, and she said she would phone me back this afternoon. And she hasn't phoned me back this afternoon. And it might seem stupid, but you've waited for that person to phone you back, and you haven't done it. So if you can't phone a patient back, or you can't arrange a scan for tomorrow or next week, then just say that. And make sure that the expectations are really appropriately and expertly managed. And manage hope, which is something else that is a very difficult thing to do, to manage hope and reality, because there's rarely nothing that can be done. It's just the focus or aim that changes, and obviously to focus on quality of life too. We try to obviously promote evidence, excellence and evidence-based, so consistent and reliable information, enabling patients to make informed choices, and that's really, really important. It's their choice, and they need the information to make that informed decision. Providing guidelines, and looking at competency frameworks, and that's been really important in the nursing community. So we did a survey, which I presented last year at ENETS, looking at what level of confidence nurses had in treating patients. And we had 48.6% of the 208 nurses globally saying they're not confident to support their patients. So that's half of the nursing community that care for patients aren't confident to do so. What impact's that going to have on the patient community? You're relying on your healthcare teams to know what they're talking about, to be confident and provide you with confidence in order for you to move forward. And if you can't do that as a nurse, then that's a very difficult place to be. So we have to address these issues. And one thing that we're trying to do, and I'm not expecting you to read this, is to look at competencies. The reason these are 2 pages of them, and they're quite small writing, but the fact being that there's very different levels of expertise within the nursing community too. So you'll talk about the competent nurse, and there's a level of and there's areas that they have to demonstrate to be competent. There's a proficient nurse, so you're really kind of moving onwards and doing more in-depth things with the patient, and you have more knowledge and getting involved in research, etc. And then there's the expert nurse, which really ends up, certainly in the UK, as being somebody that will run their own clinics, that can prescribe medications around that disease area. So we could prescribe somatostatin analogues and that kind of thing as a nursing community. We would probably see all of the stable patients. We would plan for x-rays and scans, and that all comes out of an expert nurse. So it's quite an important role in the UK, and certainly holds quite a lot of responsibility. So currently we're working with a group of nurses in the UK to develop a competency framework for neuroendocrine nurses to ensure that they have the correct information, and obviously to boost the confidence. I mean, we have 12 centres of excellence in the UK, but we still have a number of nurses, 60 of which that I met a couple of days ago with an Ipsen meeting, who don't feel also that they have the confidence that they would like to have. And obviously, finally, we try and ensure that there's a patient there to really share their story and to share their impact face-to-face with the community that we're trying to train. And that's probably the most important part. And you kind of get silence in the room, and you kind of get people really focusing because someone's sharing something very personal with you. So that's been really important. Obviously, we're going to try and continue this work, develop the competencies, and we've got sort of 5 or 6 new other programs in different hospitals now, where we're looking to go in for an hour and train some of the F1 doctors and the trainee GPs. But I think it's a responsibility that maybe we all have to ensure that the junior side of things learn things as they should be. It's quite hard to change people's ideas, when they've been doing the job for 30 or 40 years. But those who have just started, I think we have a chance to raise awareness of neuroendocrine tumours within that community, and obviously make a difference for the patient ultimately, which is the key outcome. So that's that from me. Thank you.